Hello, everyone, and welcome to Training to Save Lives inside the new world of pre-hospital emergency blood transfusion simulation presented by TacMed. These virtual learning labs are held each Wednesday at 2 p.m. Eastern, hosted by members of the SSH Corporate Roundtable. Note that this session is being recorded and will be posted to the online learning section of the SSH website later this week. And with that, I will go ahead and turn the session over to Dr. Dan Irizarry with TacMed.
Hi, everyone. My name is Dr. Dan Irizarry, and I'm the Chief Medical Officer for Tactical Medical Solutions. We are very excited to be able to present to you some information about pre-hospital blood transfusion, which is up and coming in the world of emergency medical services. Just a little bit of background for me. I'm a trained family physician, spent 26 years in the Army. Much of that time was spent training soldiers and medics in the field in pre-hospital care. And the last part of my career was establishing and developing simulation capabilities that trained the Department of Defense. From 2018 on, I've worked with TacMed Solutions in training first responders and other agencies on trauma management with TacMed Solutions. But I'm supported by a great team today. We have today with us Randy Schaefer, and I'll let Randy talk a little bit about why she's here today.
Hi, my name is Randy Schaefer, and I am an emergency trauma nurse. I did 20 years in the U.S. Army. When I retired, I had the privilege of setting up the country's first regional pre-hospital blood program in South Texas, setting up 18 helicopter bases and 12 ground agencies. And now I have the privilege that I get to help EMS agencies across the country set up their programs, recognizing that different parts of the country need to tackle issues differently. And I'm pleased that I get to partner with TacMed as we look at some of the training and simulation that I think is going to be so important to having successful blood programs rolled out.
And also with us today is Dan Stout. Dan, why don't you tell them a little bit about your background?
Hey, Doc. I was a field radio operator in the Marine Corps Reserve while I went to school, and I ended up serving 25 years in civilian law enforcement and retired in 2018 as a police lieutenant. So there's the whole Lieutenant Dan thing. Have fun with that. One of the things that made my career a little bit unique is that after the Columbine high school shooting, I felt called to go back and cross-train as a paramedic. So I did 3 years becoming a paramedic and then spent 14 years serving as our SWAT medic and leading and opening up our medical capabilities in law enforcement down in Florida. Worked a lot with TacMed Solutions after they were founded, purchased a lot of equipment from them over the years, and was able to parlay that into my retirement job. So here I am today. Normally, when I support webinars and stuff like that, there's usually some experience or expertise that I can draw on to contribute to what we're here to talk about. It's the exact opposite today. This is not a capability or anything that was on our radar when I was out on the road doing law enforcement and EMS. This is like Star Trek to me. So I'm coming into this relatively blind. My knowledge of blood transfusion, whole blood, is pretty much from reading journals and sitting through lectures at seminars and conferences and things of that nature. So I'm excited to continue to learn more about this and see how TacMed helps roll these programs out nationwide.
And Dan, you're not alone, because pre-hospital blood transfusion is pretty new to the country, isn't it?
It is. So in the military, we have a lot of experience with it, but really on the ground side, it wasn't until 2016 that the first ground EMS agencies started carrying initially component therapy, packed red blood cells, and plasma, and then in 2017 converted over to low titer positive whole blood. Since 2016, we've now grown to over 265 ground agencies across the country. I was able to run that data recently. So you've seen just a skyrocket of interest and implementation of programs.
And this is being implemented at different levels. So the organizations are working at the national level to change policies and procedures, state levels, and at the local levels.
Absolutely, absolutely.
So if you're seeing this today, you're ahead of the power curve in what is definitely going to come down the pathway. I mean, this is really, we really got involved with Stop the Bleed after we saw lots of folks who have situations, active shooter situations. Mm-hmm. And this is the next step. This is the next wave of, I think, a change in care. And that's why we wanted to do this, was to make sure that simulation is ahead of, and the training is ahead of, the implementation of these processes. So TacMed Solutions has actually been in this business for a long time. The company started around 2003, I would say, when we were started with tourniquets and started the first tactical medical training for how do you operate in a dangerous environment and balance care with security. And then over the course of time, we've developed more skills and capabilities to help first responders. And now we're launching a new program, which is called the Blood to Go program. You'll see here some of the logos for Blood to Go. The goal of Blood to Go is to give organizations a one-stop shop where they can get expertise, equipment, and training, and the long-term logistical supply to have a successful program. Now, we're going to have a lot of information that's going to be presented, and if you want more information or have questions, I'd encourage you to send an email to info@tacticalmedicalsolutions.com. That's info@tacticalmedicalsolutions.com, and we'll put that in the chat box.
Actually going to correct that a little bit. It's info@tacmedsolutions.com, TACMED solutions.com.
And thank you for the correction.
No worries.
And that'll be in the chat box. We also have some folks from the organization who will be able to answer your questions as you raise them. So please ask questions as you go in the chat box, and so that they can get back to us, and we can get your questions answered. So I really developed this training along three big questions. How, first starting with why, then how, then what. So we're going to talk about why. Why pre-hospital transfusion? Why is pre-hospital transfusion an issue today? And what do we know from the research, Randy, as to what it can do for folks?
Yeah, so it's of interest because we have a lot of people dying in this country, bleeding to death before they ever get to the hospital. And largely these are preventable deaths. So with good, bleeding control, we need to replace what's lost. And now the technology has come along so that we can push the concept of blood transfusions out into the field. And the goal is to really go after that morbidity and mortality associated with preventable deaths.
Now, I've heard some numbers quoted as high as 30% potential improvement in survival if you get blooded within a timely manner.
Yes. So, we are even not looking at some of the National Highway Traffic Safety Administration is looking at even some of the fatalities. 40% of all motor vehicle crashes in the U.S. Were alive at first contact with EMS, and either died while EMS was on scene or shortly after arrival at the hospital. Still looking at the data to sort out if those were preventable hemorrhage deaths. What can we do to increase the survivability? And this is one tool.
And it makes sense. If you lose blood and you get blood back, you're more likely to survive by getting blood. We know that other fluids don't do what blood does, and so that's a huge piece of it. So pre-hospital transfusion is critically important, and it is coming. It is definitely coming to a neighborhood near you. So the question then is the training. What are some of the training challenges? There's really two training challenges when you implement anything new. If you think about Stop the Bleed, we had to teach people individually how to use tourniquets. And then we had to work with systems to be able to implement those processes and protocols into their things. Talk about some of the training challenges, Dan, individually that you can think of as to what we ran into with the implementation of the tourniquet.
Sure. Going all the way back, when I first started in law enforcement, we had very, very minimal first aid training in the academy. And even then, the typical response, not just in my agency, but anywhere, was ambulances before cops. Somebody was jacked up, we would run code to get there and call for an ambulance. And really, there wasn't a lot being done for the victim until the ambulance got there. Shame on the first responder community for allowing that to go on for so long. But I was part of that. And like I said, when Columbine came along, felt convicted to do something different and better about it. And over the years, it wasn't a quick, it's like turning the aircraft carrier. It doesn't happen quickly. It takes years, but slowly one agency would come around, then another agency. And, nowadays to find an agency not doing that is more of the oddity. But it took a long time to implement that. It was accessibility and it was acceptability. It took a while. It's just like AEDs, the witchcraft and wizardry in that box on the wall. People were very terrified to go get that in play, mainly because of misconceptions, misinformation, things of that nature. So with good education, both just generic, what is this? Why are we doing it? And then actually, how do we do it? And then there was budgetary issues. So those were always challenges to fight uphill and get those implemented. One of the things I was talking with you guys about this morning was when we rolled our program out, we thought we did a really good job bringing all the stakeholders in our community to the table so that everybody was aware of what was going on. The law enforcement, the fire, the EMS, the trauma center, the helicopter, everybody kind of knew what we were doing. All right. And we all agreed, yay. What we didn't think to do was to go far enough into the system to speak to the surgeons that would ultimately receive these patients in the OR. And we caught a surgeon off guard one day by bringing in a patient that had been packed with a hemostatic agent. So being able to know how far into the system you need to go and things of that nature to brief everybody up and get everybody, all your stakeholders involved, that'll help avoid some hiccups and some bumps along the way. And I envision the same type of needs and communication and liaison is going to be vital to make sure a successful rollout of this program happens. Yeah. So lessons learned from previous experiences.
So we have to simulate the system, but looking at the individual level of training, we're going to talk about system simulation, but looking at the individual level of training, Randy, what's the status of paramedic training and transfusions?
So right now, there's very little exposure to paramedics during their formal training when they go into school, whether it's about, basic management of blood products, how to transfuse blood, what transfusion reactions to look for, much less the management of the product. So there's always a lag, in academia as we roll out new capabilities. So a lot of the blood programs are having to do it in-house, coming up with their own training programs. And that's why I'm a huge fan of events like this, so that we can start formalizing that process, especially as we're starting to move, into that bell curve of change. Change theory, you've got your early adopters. Now we're moving into the middle where we are going to have explosive growth. And we want to make sure we provide the guardrails and help agencies do this safely and correctly.
And the guardrails really come to how we train and how we simulate that. I think that's one of the powers of simulation is we establish those norms and processes or that train a system. And this is not a small system when it comes to providing blood to the person. It really is broken down into several pieces. The first is, and the most probably important piece of the system, is who you get your blood from. And getting that blood, giving that blood to the administrators, the organization administrators, is really tied to trust and verification that they're capable of doing that. And that's really tied to a good training program. So you really have to understand the training program for the system, and you have to share that from the blood supplier. It has to be accurately and effectively implemented at the blood administrator. And obviously it's most important for the patient because the patient. So when you think about when you've done your MassCal simulations and you've got all these different organizations involved in the process, this is a very similar system that has to be trained. And what would you say is the training value for the organizations when we do a thorough simulation?
So it brings together folks who may not work together on a daily basis. And doing pre-hospital blood is not like any other clinical intervention. You can't just get on a website, buy a widget, copy and paste a protocol and say, hey, we're ready to implement our programs. You will have to talk with the hospitals. You will have to talk with the blood suppliers. So it's that similar concept of bringing folks together so that we can make a really strong, solid system. And by the way, when we do it correctly, at the each level, the patient level, when a mass cal or some other event occurs, it's just a scaling up of what we've been doing every day.
Right. And it has the whole blood transfusion process in pre-hospital setting has special equipment that people are not used to using as well.
Mm-hmm.
So there's a cold chain management process that, when it's in the hospital, it's straightforward. You pull the blood from the refrigerator, it's been in the blood bank, it comes to the ER, it gets administered. And no one really worries too much about what the temperatures have been from point O, because we know the system always works. But now we're transporting this in trucks and we're having to maintain that the cold chain and document that cold chain has been maintained for a lot of different reasons. Then you have special equipment that are part of the IV system and the warming systems and the pumping systems, if they're used, all to get to the patient. So the training value of doing good, solid simulation in this can't be really underestimated. Now, that's the why. We spent a lot of time talking about why. I want to talk about how. So training design, one of the ways that I've always designed training is using the ADDIE model. This is a common model that you may be familiar with. The first thing you have to analyze who you're training, and you get your learning objectives. And I think the biggest learning objectives depend on who your learners are. But in the pre-hospital care system, it's really learning about stopping bleeding, getting blood, and giving blood. And the elements associated with that. Then you design that training, and then you develop that training, implement that training, and then evaluate your training. And so when we developed this training today, we use the ADDIE model. The other thing I always talk about, and this is maybe an Armyism, but it's also ubiquitous throughout other trainings, the crawl, walk, run process. So we like to start with partial task trainers, and you can get different partial task trainers. This is a simple arm that has a connection that allows for blood to be pushed through to give you a pulsating wound that a tourniquet can be placed on. And so we like to start with simple task trainers like this, or our wound packing task trainer, which again has a very realistic wound, simple to use, plugs in a small port to add fluid, and that allows you to do wound packing. That's kind of the crawl phase, and you can do that easily with a lot of folks. This particular mannequin is also designed to be a task trainer in and of itself, because if you look at the mannequin, it's in two halves. So the lower half is really designed around blood management and hemorrhagic control. We have a wound that will obviously we'll demonstrate that in a minute. And then it has a wound that needs to be packed, which we'll demonstrate in a moment. So that gives you the opportunity to work on part of the body, but then you still have to maintain the airway and do all the other things. So when I do training, I start with stop the bleed with some of these small task trainers. Then we break off groups into working on the lower part of the body, while someone is managing the airway and doing the appropriate management for the rest of the body. And then we go to the walk phase, where we manage one whole casualty, and then we go to the run phase, where we might manage multiple casualties. And so when you're doing your blood transfusion simulations, I would recommend that you look at that crawl, walk, run phase. You also want some good, go ahead.
And folks are probably wondering why we're talking about stop the bleed. I mean, the first step in all this is that you recognize that there's a life-threatening hemorrhage happening. You immediately try to stop the source of that bleeding, and then we work on replacing what's lost. So that's why we're doing a bit of emphasis on bleeding control.
Yeah,
as part of the pre-hospital blood transfusion.
I was doing some training in DC last week with some personnel, and I stressed to them, there's a lot of really cool high-speed, low-drag medicine. If we're not doing the meat and potatoes, though, the simple stuff, we'll never get there. Mm-hmm. You've got to stop the bleed. You got to deal with just head, tilt, chin lift. That basic stuff is what wins the day and gives you the chance to implement this really cool stuff.
Right, which gets to what do you teach? And before we get exactly into the what do you teach the content of training, there are some standards that are being published right now today that you should be aware of. One is by the AABB. It's the Emergency Pre-Hospital and Scheduled Out-of-Hospital Transfusions Standard. This is the first edition. It was just published.
July 1st, they went into effect.
And can you talk a little bit about AABB and their role in this whole with pre-transfusion?
I can. So, disclaimer, I was on the committee that helped write the standards. The standards were born out of a need to provide some guidance to the blood community and to pre-hospital providers on how to safely and from a regulatory standpoint, meet all the requirements of a blood transfusion program. There is a code of federal regulations, and the CFR and the FDA, the Food and Drug Administration, has oversight of blood products, and the AABB is an accrediting agency. Similar to what many of you may see in the Hospital for Joint Commission, the AABB did largely hospital and some out of hospital, but they had new standards for pre-hospital care. And we needed to come together, you know, the pre-hospital world and the blood community and the hospitals to figure out a manageable way. We can't make every paramedic on a truck a blood banker, but there are absolutely things that have to be done in order to have a pre-hospital blood transfusion program.
And so as we develop this curriculum for the Blood to Go program that we offer as part of the onboarding of an organization, we have developed the curriculum to align with these standards, and that's kind of making sure that they learn the critical key pieces from the outset that you want to put in your simulation. The other reference that you'll want to take a look at is the Pre-Hospital Blood Transfusion Coalition's Clinical Practice Guidelines. Randy, can you talk a little bit about that?
Yes, so the Pre-Hospital Blood Transfusion Coalition is a grassroots effort at the national level to bring together all of the stakeholders to help remove some of the barriers to EMS agencies adopting these programs. And as we have seen the growth of the programs across the country, again, since it's not being taught in you know, their early schooling, or it's not found in textbooks, that we wanted to provide a source of information on things that you need to consider. So the military, we use clinical practice guidelines for maybe 2 decades now to help guide the care. It's not prescriptive, it's not policy, but again, it serves as a guardrail. So these are things you should consider when you're having your program.
So when you're building your simulations, you definitely want to look at these 2 references. The third place that I would look to for information is the Spark Academy. And Randy, tell us a little bit about the Spark Academy.
So the Spark Academy is the Selective Pre-Hospital Advanced Resuscitative Care Academy. That was a mouthful, but I got it out. And again, it's a group of volunteers that are coming together to pull concepts together. So you may learn about Stop the Bleed. You may learn about pre-hospital blood transfusions. You might hear at a conference something about TXA or calcium or ultrasound, but what does that look like when you pull it all together, when you come up to the patient's side? Which order do I do things? How do I approach the patient? So the Spark Academy is going out and working with interested, you know, bedside, stretcher side medics, leaders within EMS systems, hospitals, the blood community, so that again, it's another vehicle that we can help provide guidance to the pre-hospital community.
And uniquely, what Spark Academy does, EMS, you'll be at EMS World. The next one will be at EMS World in October.
Yes, October. I think it's 21st, Tuesday at 8 a.m. is a pre-conference offering.
Yeah, in Indianapolis.
In Indianapolis this year is EMS World.
So what Spark Academy does is they provide some didactic information, but they also do a lot of simulation in the process. And because it's important to have not only the head knowledge and the heart knowledge, it's kind of the Bloom's taxonomy, that head information that you need to have and the heart information, how quickly you need to do things, but you also have to have the hand knowledge. And that's where really developing your content is going to be key. You have to get all 3 of those elements into your simulations if folks are going to be able to do pre-hospital blood transfusion. Which gets us to the fun part, which is content and what do you teach and how do you teach it. So what I like to do is I break down pre-hospital blood transfusion into 3 parts. 1, stop the bleeding. 2, get the blood. And 3 is give the blood. So when we developed our training, we start with stop the bleeding. And we're going to go through how we teach stop the bleeding so that everyone gets a chance to see what we're doing. In pre-hospital blood transfusion, one of the first things you have to do is you have to ID the patient that might be a candidate for blood. And so on this particular Manikin system, we have the ability to feel for pulses, and we have the ability to determine the rate of the pulse. We also have a monitor that tells us what the pulse is at a particular time, assuming that it's running as I get it started. And you can see that he's bleeding fairly effectively right now and probably needs to be stopped. Dan, can you stop that bleeding for us?
So anything that's on an arm or a leg and is major hemorrhaging, we're going to apply a tourniquet first. We're using our soft tourniquet by TacMed Solutions here today. I always deal with the tourniquet first before I deal with anything that's wound packing, because I can generally get this dealt with in about 30 seconds versus wound packing, which is a 3 to 5 minute process. Right? I just happen to have advanced knowledge that that's where the wound is at. So here, we're going to take this, pack. Some people make a little speed ball before they put that in there. I don't think that's as vital. The big thing is don't give up the pressure in between what you're doing. Maintain even consistent pressure on it till you can't get any more into that cavity. If it's a hemostatic agent, you're going to hold pressure for 3 minutes. If it's a non-hemostatic agent, you're going to hold for 5 to 10. And the one thing that I see a lot of people do is they want to hold pressure for 30 seconds and then lift their hands up and see what's happening. You have to trust that the magic is happening. When you get to the end of that time and you lift your hands up, the bleeding has stopped. You'll need a good trauma bandage to help secure it in place so that you can go do other things for the patient or other patients. You don't want to have to stay hooked up to this guy. Normally, I would have come around to the other side of the patient. We'd be doing this from the ground, but for the purposes of cameras, I'm leaning over the patient to get to this wound on this side. So again, wound packing, it's still an arterial bleed. It's just in those junctional areas, places that we cannot get a tourniquet on. So mainly the pelvis and the meaty parts of the shoulders. And basically, we're filling up that wound with gauze. Again, hemostatic agent sometimes, non-hemostatic agent if it's not available. But we're packing, holding pressure, and that is just helping that wound to stop bleeding.
So we saw the bleeding and we stopped the bleeding, but when we assess the casualty to determine, we got to be looking for things like specifically hemorrhagic shock. What are the signs of hemorrhagic shock? So in the curricula on the Pre-Hospital Blood Transfusion Coalition's criteria, one of the things that you're looking for is a systolic blood pressure that's less than 90, right? And which you could check for a pulse if there's no pulse at the radial. And in this particular Manikin, the physiology aligns to that. So you have no pulse. If you have a systolic blood pressure less than 90, there's no radial pulse, but there will be a carotid pulse. You want a heart rate that's elevated, tachypnea, and potentially an ETCO2 of less than 25. And so, but one of the biggest things that you're looking for is twofold: a change in mental status. So in this particular Manikin, we can actually talk two-way communications through the head. And so we can be the patient as we're working through the process. But one of the things I like to do in simulation, you might have noticed that the Manikin was moving before and kind of shows signs of life. But when you become unconscious, then people stop moving. And that's a really good clinical indicator that things are going bad and that you can put into your simulations. So you want something that triggers the learner to realize that things are not going in the right direction. And then that gets you to the answer of the second step. You stop the bleeding, get the blood. And that requires triggering a system. So how are systems doing that nowadays? You're familiar with the number of EMS programs that are doing this. How are they triggering this system?
So by and large, from a logistics and a financial standpoint, systems are using supervisor vehicles to be creating a blood medic. So the very first, medical contact or even law enforcement contact, recognizing that this is a really sick patient, that they can call for the blood medic to start bringing the blood to the scene. I would like to start thinking in terms of cardiac care of, instead of, someone go get me the AED, or if one's available, or call, EMS, that we're same thing, get the blood en route and moving towards the scene. Or if you happen to have it on your vehicle and you are the first responder, then you go to your truck and grab it.
Yeah.
Or off your apparatus. We've got apparatus out there that are carrying it. We have law enforcement, tactical teams carrying it. So whatever works best for your system, you need to know how to activate that blood response.
That's right. So we've all done this with ACLS, right, where we started with, listen and feel. You in the blue go for help, or it's ACLS, but it's really not ACLS. That's
BLS.
BLS.
Right.
But right, so and we practice that in the simulation. With these simulations, you really do need to understand how your system is triggered and practice with those organizations and with your students how to trigger the system to get the blood moving in your direction. Because it's probably not going to be on every ambulance. It's just not capable of being able to do that. So the first piece of your curriculum is stop the bleeding. The second piece of your curriculum is get the blood. And the third piece of your curriculum is actually giving the blood. How does the blood get given? So there's a lot of steps to giving the blood. One of the parts of triggering the system is getting the blood. This is a Rini technology blood cooler that is being under development. There are a number of coolers on the market that provide capabilities to make sure that blood is transferred in accordance with AABB standards. So you really need to have a cooler system that is either the ones they're using or representative of a cooling system, because there's information that has to be pulled from that system that later has to be documented. What is the information that you need to have from the cooling system, Randy?
As far as while it is being transported or while it is in storage, you have to monitor the temperature of the cooler to make sure that it stays either between 1 and 10 degrees Celsius or 1 and 6 degrees Celsius. And that specific number will be laid out in your blood service agreement. It is an FDA requirement that at a minimum of every 4 hours, the temperature of the product, while it is either in an active cooling system or a passive cooling system, is documented. And then the capability has to have an alarm, so that if there is an excursion, either too cold or too warm, there's a triggering alarm that some action needs to be taken and bring awareness.
So in your simulation, you need to be making sure that there's a process by which the learners are looking for that information, gathering that information, and maintaining that information. Because the first step is getting the blood, and after you've gotten the blood, you've got to kind of check the blood.
Yeah, you have to verify that the bag is safe within temperature.
Right.
And so that is the first step, is pulling it out, making sure you've got the right product, with the it's not out of date and that it hasn't gone out of temperature range.
Yeah, we can see the Rini closer. Let's pull that. Can we show that a little bit later at the end, because otherwise it'll make it a little more challenging. So that's part of triggering the system, is getting the blood, checking the blood, making sure it's the right place. When you give the blood, the next thing you have to do is you have to gain some type of reliable access to the vascular system. So there's a couple of ways we can do that. We can start IOs in the humeral heads, or we could start IVs in the
Wherever you can get one.
Wherever you can get one, exactly. And did you say there's more IOs being used today over IVs?
It's a mix. It's maybe some systems is 50-50, some it's 60-40, depending on the severity of the trauma or the level of hemorrhagic shock, right? Because it's much harder to get an IV line in a patient that is already having that neurovascular collapse.
Right. So, and then once you've gotten a good, reliable access, then the next step is to be able to start putting the equipment together and ready the equipment that has to be put together in order to get the blood. So that starts with the blood bag, and then it works down the process. So can you walk us through what we have set up already today?
Yeah, so in the interest of time, we're not going to set it all up, but here's an example of where You got your blood bag that's been verified. We've done our visual inspection. We've made sure it's the right product type, that everything is good to go according to the guidelines that are set forth in the standards. We've primed the line, we spiked the line, we primed the line. There's two pieces. You want to rapidly infuse the product and warm the product. So there's different ways to rapidly infuse it. Here is one example of a really easy way to have a rapid infusion of the product. And this is the LifeFlow by 410 Medical. This is actually compatible with, here's an example of a warmer by Q&Flow, and they are compatible into the same line so that you can have rapid infusion and warming of the product at the same time. So it's important when you're looking at your equipment to make sure that the systems are compatible with each other.
And we had a discussion earlier about there's at least one organization that talks about giving blood that's cold. That do you really need a warmer? And I think you had a great example of you have to consider your environment. Can you talk a little bit about that?
Yeah, so in the military, we feel pretty strongly that we know hypothermia really contributes to overall mortality.
Part of the triad of death.
Yes, absolutely. It's so important. It's part of the triad of death. So I also live in a real world where sometimes you have an equipment failure or things don't work. So would I give blood that is not warmed in a scenario where I didn't have a warmer available? But I think the best practice is probably to warm it. And the technology is so small and so compatible for the pre-hospital setting. We're not talking big equipment that you used to use in the hospital. And thinking about your system. So if you have really, really short transport times, you might not see the effects of, giving a couple of units of cold blood. But if you're having longer transport times and you are not making really active attempts for active warming, I think you definitely have a risk for hypothermia. If you're maybe in a warmer climate, again, with those short transport times, it might not be as important. But, I've talked with agencies in Alaska and Minnesota, and absolutely, you need to be warming blood.
Right. So when you're doing your simulation and you've got them, they've put on the systems, the monitors in place, the IV infusion is in place, and you're ready to give the blood. You've set up all the equipment that you need, that they're going to use, and there's some other things that are supportive medications that you may think about in the process. So specifically, some of those are TXA and calcium, and why TXA is pretty clear. You give TXA when people is bleeding, and it can help with clotting. What's the story with calcium?
I want to go back to the TXA really quick. So not all systems are using TXA. And part of the challenge was giving that 1 gram and then 8 hours later following it, making sure that that second gram was given. But now with the new guidelines are coming out, it's doing 2 grams IV push at one time.
2 grams IV
which is a lot easier, especially as the patient is going through handoffs.
Right.
So TXA definitely should be considered in your protocols. And calcium, we are looking at the effects. Now we used to give, or we still do give calcium because these bags contain a citrate in there that we need to give the calcium to offset some of the effects of that. There's also a thought that as we lose blood, we are having damage to the clotting factors, right, which calcium plays a role in the clotting cascade. So that might alter a patient's calcium level. So there's several research studies going on right now about what's the optimal timing, what's the optimal value. We don't have iStats in every medic's pack out there. So trying to figure out the sweet spot. The Coalition for the Clinical Practice Guidelines, after 1 or 2 units of blood, you can consider giving calcium. And there are agencies out there that, looking at from a bundled approach, I think is probably the right answer of the blood, TXA, and calcium all working better together.
So when you're thinking about your simulation equipment, you have the blood, you have the warmer, you have the infusion pump, and how you're going to get the blood into the person fast. some other medications, TXA and calcium, that would be considered. And this was particularly interesting, which Randy brought up, was this issue of pain control. You know, when the person has hemorrhagic shock and they go unconscious, you're not terribly worried about pain. But when you give them blood back, what happens? Well, their brains perfuse, they wake up, and guess what? They feel pain again. So one of the things that we like to do when we do the Spark Academy simulations is we start with a person who's talking, and then they eventually go to where they're not moving. And then after we give the blood, we start that person moving again, and then we start them talking again. It gives the users a sense that the blood did something, and that it brought back a to some level of consciousness, or some improvement in capability. And there's a pretty good story of a girl who received, she had, and this is another thing, it's not just about traumatic injury. There's other reasons that people lose blood: gastrointestinal hemorrhage, maternal hemorrhage from a birth at home. In this particular story, which you can look up on the internet, the young lady had a tonsillectomy, and she had a severe bleeding from tonsillectomy, basically went unconscious. Her father happened to be in the fire department system. When he called 911, he said, "Bring blood," because he knew that his organization carried blood. And they brought blood, and she basically came back to a normal person in seconds to within a minute during transport.
Yeah, it's important because she was able to start managing her own airways, so they didn't need to intubate her. And a great example, so that was on NBC News, the story of Izzy, and when NBC News is doing an investigative series on pre-hospital blood. So again, she went from unconscious, the paramedic did everything beautifully. It was a non-compressible bleed, but saw that she was at risk for, quickly to go pulseless and unresponsive, got the blood going, did just basic airway management, and be able to get enough level of consciousness that by the time she arrived at the hospital, no intubations and no surgery needed.
Right. So that's really becomes an interesting question when you've got a person that you've probably intubated because they went unconscious, and now you've given them blood and they start waking up. What are you going to do with the person who's intubated, who's now starting to wake up because you gave them a life-saving intervention? And these are some of the things that, as you assess your patient, administer blood, and assess your patient, you need to think about in simulation. The next step is monitor and document your patient care. And the documentation for this, we're all pretty comfortable with documenting for a trauma casualty like you see forward here. But what we're not aware of is the critical information that has to go into documentation for when you give blood. What are some of those key pieces of information?
So you need to get with your EPCR, electronic patient care record vendor, and making sure that blood is added to your documentation. So you need to write the specific type of products, because we've got agencies using many types of products out there: low titer O positive whole blood, low titer O negative whole blood, O negative packed cells, plasma. So you need to have the very specific product type in there. You need to document what time it was started and what time it ended, and the mLs that are infused. So when you donate blood, it's collected by weight. If you ever look down, there's a little scale down there. So there is some variability between bags and product types of how much volume is in there. So that's why you need to document either CCs or mLs that were administered, or just a couple of examples of things that are new that you need to document. You also need to document it as a medication. And the coalition I'll make a pitch for the coalition, is working on getting reimbursement for blood products. And a huge piece of this is appropriate documentation. So we are going to have to teach agencies how to properly document this, not only from a clinical care standpoint, but so the billers can go in and extract the information so that they can submit it to the payers.
Right, and if we build that into our simulations, then that becomes the foundational response that people are going to do, and then that will subsequently lead to things that what we need them to accomplish. You also want to think about practicing some of your pitfalls that can happen in simulation or in the real world, where your equipment doesn't work, or there's a problem with procedures. And one of the interesting things that I think is working with the decision for multiple casualties and not enough blood. And so those are some other contingency things that you could think about when you're doing your simulation training. So do we have that slide? Is that possible to bring up the slide? What we've covered basically, I have summarized in something we call Stream. Hopefully that slide's coming up, guys. Okay, this slide's coming up. So what Stream is a simple acronym to take you through the contents of the blood transfusion first program, or the pre-hospital blood transfusion program. First is stop the bleed, so that's the S. T is trigger the system. R is get reliable access in the patient. E is ready your equipment. A is administer the blood and assess the patient. M is monitor and document the patient. We've covered today that in training design, you want to use partial task trainers early if you can. Use the ADDIE model to develop and redevelop your training. That it's better to go crawl, walk, run. And you want to build resources in place that you reference your curriculum against good, solid resources that are coming out as we go. That on that slide, you can also see that I might have the wrong email. Check the email there. Okay, all right. I have the right email this time on the slide. Information, and we also give you some overview on the Blood to Go program. Really, the Blood to Go program is what we have several experts, Randy being one of our key experts, that provides that level of expertise that organizations need to develop their training and actual processes. We provide the logistical support and all the equipment that you need to do that. We have the educational processes in place. So what we have is the ability to do online training through a Sarago platform that you can learn on your phone, the necessary heart and head skills. And then we have a simulation-based training process that allows for, we're good with the slide there. The simulation-based training process that uses the trauma mannequins you see today so that we can do a ramped training capability that makes sure that your folks can do what they need to do. And then, of course, the key is to do it. The easy button is that it's all under one contract, so that allows for one point of contact to get all the capabilities you need. That's the Blood to Go program in a nutshell. But really, from a simulation perspective, one of the most valuable things that I've seen related to the importance of simulation was a statement made by a first responder who had responded to the Pulse shooting. And he said, we need good simulation and training because the body can't go where the mind has not been. That's so profound. The body can't go where the mind has not been. Or it will go there, but it won't go there well. I mean, we all get dragged into situations. But that's the beauty of simulation, is we put people into a situation, they put their minds into a situation that they've never been before, so that when they get into that situation again, they are going to be more efficient and effective at that. So Dan, here he is. How do you feel about where you are in learning about pre-hospital blood transfusion?
It's one of those things, being retired out of the field, you look back on your career, and I can think of a handful of calls that had negative outcomes that, I wonder, had we had this capability, could it have made a difference? Because we gave them the full court press, everything in the field, transport, and like you said, at some point during that event, they just passed. And knowing these capabilities, what it's able to do, the statistics behind it, I'm excited for the next generation, the current generations and the next generations of field providers that are going to be out there with a tool that wasn't available to me back in the day. What are they going to be able to accomplish, and how much more are they going to be able to do for the patients in the field? And I think those outcomes are going to be outstanding. And
how about you, Randy? Where do you think I thought the American Red Cross statement that you just presented or showed me today was very impactful to me.
Yeah. So again, it's new relationships, new folks that are coming together. Had the opportunity to be at a national event yesterday where the chief medical officer for the American Red Cross probably expressed what many folks in the blood community are thinking about, that they know that this is a new capability for you. And why I was laughing at your comment, in the hospital, nobody worries if it's been cold. The blood bankers worry.
Oh.
They absolutely worry, and that same worry is there. And when we put together a good training and education plan, I think it helps build that trust quicker so that we can get these programs widespread.
Yeah, and a good, clear simulation that shows that your people have been, quote, really run through the process would give the blood bankers more confidence that this is the simulation, this is the head, heart, and hand knowledge that we have given to these folks before you've even given the blood. So I think that's really important. Someone asked about this Rini. We're calling the mini Rini. So it's a smaller refrigerated. It's basically a mini refrigerator. It operates off of a battery that is on the outside right now, and this is under development. Pretty straightforward. Place the bags in there.
And it monitors the temperature.
And it monitors the temperatures and keeps the temperatures at the same temperature that it needs to be with in transport mode, or even in storage mode, because there's a difference between storage and transport mode. And then there's a system in place on this side that allows us to gather data and get data. But again, this is under development. It's been being developed by the military right now, and will be further developed for the EMS world.
There are solutions right now out there.
Yeah, let's talk about that.
That are working well for some of the agencies. So Delta Development has a fantastic cooler that meets a lot of the concerns the blood bankers have. Agencies are also using the Pelican containers. So there's options out there. I'm excited. There's more options coming out that will meet the needs of both the blood community, the hospitals, and the EMS agencies.
I think one of the biggest things is just don't go out and buy the equipment that you, without having the expertise behind making wise choices.
Yes.
There's been some misfires.
Yeah, so with the proliferation, did I get that one right? I was at the top of the hour here. That folks think they can go onto a distributor website, click a few items, and Google a protocol, and that they're good to go. Please don't do that. This is, again, like no other clinical intervention. You will save yourself time, heartache, and money by getting in early with some of the experts to help you.
For sure. So that pretty much wraps up the content that we intended to provide for you today. The learning objectives were that you'd have an overview of pre-hospital blood transfusion. You'd have a better understanding of how to create a curriculum around that. How are we doing for questions? Are there questions that are on the... No questions. Okay, all the questions have been answered.
I know the one question I had earlier that y'all answered for me this morning, when somebody draws a bag of blood from the blood bank and they take it back and they put it in the cooler, as long as that cooler is monitoring and everything is working, how long is that blood usable in the field? And at the end of its serviceability, what happens to it?
So it depends on the type of product that's collected and the type of collection bag that's used. So for example, low titer O positive whole blood, there's two different bags out there. So one is good for 35 days. Another brand that citrate they use is only good for 21 days.
Okay.
So that helps give you sort of the guidelines on how long the EMS agencies can keep it If they're part of a rotation system, which we completely advocate for, because we know in the pre-hospital setting that this might be a low frequency event, but it's really high acuity, really high mortality rates. So we want to make sure that blood isn't just discarded due to expiration. So the blood can go to a hospital to be used. And that would be the optimal. We do have some parts of the country where we've not been able to tackle that. We're working diligently so that we are good stewards of the blood product.
Cool. That brings up another thing that I just thought about was related to MassCal simulations. We've partnered with Florida Gulf Coast University on their disaster management plan and simulation that they're doing. We'll do it again in November. And one of the interesting things is it's not enough to, if you have a MassCal event, now it's not enough to just identify who's what triage category, but which triage category are they and can you do something about it? So if you have a person who is triaged as urgent, are they urgent because they have hemorrhagic shock? And can you get blood to them? How do you identify the person who's urgent from an airway problem versus a person that can benefit from blood? So part of the MassCal process and planning process was teaching them to identify bleeding as and hemorrhagic shock as part of their MassCal triage program. And then that allowed us to isolate patients that might be able to get blood. So as blood was coming into the MassCal situation, that blood would be routed to the right spots. We also are looking at the Blood to Go program of being able to provide pre-hospital blood support for MassCal situations or potential MassCal situations.
Yeah, I think mass gatherings.
Mass gatherings.
Mass gatherings. So we need to make sure that blood is incorporated to any emergency response plan, whether it's pre-staged in a potential high-risk event. So a lot of options. I know we're running out of time, but you can reach out to the email if you've got a question out there. We've got one question.
Yeah, so will any of you be presenting at SimGhost in Nashville?
We're not immediately planning to do that, but I think it's possible.
Okay. Second question was, are there any PEDS specific or PED specific programs?
Are there PED specific programs for blood transfusion?
So give blood to kids. We do it in the trauma centers. So absolutely, please, 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 please include pediatric patients in your pre-hospital blood protocols.
And then the use of the life flow is something that's kind of
for
pediatrics
honestly,
well.
life flow has made this virtually I'll call it kernel proof because I'll make fun of ourselves.
Yeah.
That each squeeze is 10 mLs, and when you look at the resuscitation protocol, it's often 10 mLs per kilo, so you know the kilos, and it's 5-6 squeezes. So it's easy to have the exact volume that you want transfused.
Yeah, so that's a nice element for pediatric care is the life flow gives you a very clear number. Those are great questions. Thank you. We'll look into what the potentials are for SimGhost. Well, we're out of time. So I just want to say on behalf of TacMed Solutions, the Blood to Go program, we're very excited to have the opportunity to present this simulation seminar. Dan, last thoughts?
Appreciate y'all taking the time out of your schedule to get more familiar with this. I'm excited about it. Again, I can't wait to see what folks actually do down the road with it, and I hope that's how you feel about it as well. Randy?
You said it beautifully.
All right. Well, we appreciate all the time and the effort that you put into this. Simulation is, in the military we say all that is not war is simulation. So what you do to train people to put their minds in places that their bodies can go and will have to go in the future is life-saving. And we appreciate what you do on the front line, and where we can help you at TacMed Solutions in the Blood to Go program. Please don't hesitate to reach out. Happy to share this curriculum and these thoughts and ideas with you through the email.